Staying on top of that breaking news out of Washington, the Biden administration declaring monkeypox a public health emergency. This move will free up additional resources for vaccines, treatment, and tracking as this disease spreads across the country.
Let's take a look at where we are with regard to the recent global statistics that came out from UNAIDS just about a month ago. As you can see, in 2021, there are about 38 million people living with HIV, but unfortunately, still 1.5 million newly infected individuals with 650,000 deaths. Since the beginning of the pandemic, over 40 million people have died from AIDS.
The LGBTQ, Black, and Hispanic communities continue to be affected at unequal rates.
The UNAIDS just released a report that talks about the need for us to continue to accelerate our effort toward ending the HIV epidemic. And we in the United States know that that is true. We've got the National HIV/AIDS Strategy, which also talks about accelerating our progress and being committed, and also ensuring that funding is going to the areas most in need.
I can tell you that strategic collaboration really means that we are leveraging the expertise of different organizations across the government to improve the lives of people with HIV.
Perhaps most importantly, the strategy shows commitment from the president and the administration to bold goals. And it helps guide communities and the government and the private sector on a similar path towards ending the HIV epidemic.
It's a plan to make sure that the latest advances in HIV prevention, diagnosis, and treatment are available to everyone, regardless of their age, race, gender identity, sexual orientation, disability, or other factors. It shouldn't matter where you live in the country, or how much money you make, or how you respond, or how we have to respond across the board to HIV epidemic everywhere and support all people living with HIV.
If we take the right steps, we can make COVID-19 the last pandemic, and we can build a healthier, more equitable world for everyone.
Are you optimistic that with this new initiative and where we're going with the science, that we can truly end the epidemic and have a new way of life for young people?
I am. I don't think it's going to be easy, and I don't think it's going to happen spontaneously. A lot of effort has to be put into it. But the one thing I'm absolutely certain of is that it's possible. So it's up to us to make it happen.
Hello, everyone, and thank you so much for joining us today at the 9th Annual Synchronicity National Conference, organized by HealthHIV, HealthHCV, and the National Coalition for LGBT Health. My name is Marissa Tonelli, and I will be moderating this plenary today. Our first plenary session is on syncing syndemic approaches across government agencies, and we look forward to sharing the important content from our speakers that they have prepared, and also to providing an opportunity for knowledge transfer and idea sharing on how government and communities are working collaboratively to end epidemics. Please be sure to utilize the Q&A chat function as you think of questions or comments, and we'll answer questions following the presentations. Now, I would like to introduce our speakers. Next slide. Our first speaker today is Dr. Jonathan Mermin, the director of the National Center for HIV Viral Hepatitis, STD, and TB Prevention at CDC, and who is currently serving as the incident manager for CDC's MPOX response. Our next speaker will be Dr. Leandro Mena, the director of CDC's Division of STD Prevention, where he manages the implementation and evaluation of CDC-supported STI prevention programs in the US. Following will be Dr. Laura Cheever, who is the Associate Administrator of the HIV/AIDS Bureau at the Health Resources and Services Administration, HRSA. And lastly, Erna Hughes, the Director of the Office of Health Center Investment Oversight at the Bureau of Primary Health Care within the Health Resources and Services Administration. Her office is dedicated to creating a measurable and lasting impact on health outcomes, health equity, and health center program performance. So now I will turn it over to our first speaker, Dr. Merman.
Great, thank you very much, Marissa. And I wanted to start off by appreciating both the excellent panel that you've invited me to join and the proactive thinking that went into this conference itself over the years, because one of the specific areas that we've been able to highlight recently is how these different epidemics become a syndemic. And in my slides, I'm going to touch on how MPOX really was anticipated in some ways by the syndemic approach, and how we can be more effective in responding to it over time when we think about different aspects of syndemics. So next slide, please. Next slide. Okay, so first, we tend to think about syndemics as affecting both people and populations, place in terms of either geography or venue, that there are often syndemics can be responded to most effectively through large-scale policy changes as well as small policy changes, and that there continue to be scientific advancements that if we think about our health situation through a syndemic approach, the science can be more effective. Next slide, please. I have no conflicts of interest. Next slide. So MPOX is an orthopox virus, and that is, it comes from the same group of viruses that can cause smallpox, or the vaccine for smallpox, or cowpox virus. And it was first discovered in 1958, following 2 outbreaks of a pox-like disease in colonies of research monkeys, which hence its previous name. And what's happened over the past few decades is we've started to see increasing numbers of cases and outbreaks. And that's mostly in Central and West Africa. And it's been attributed to both a reduced vaccine-derived immunity because we no longer vaccinate people for smallpox. And so most people who had it as a routine vaccination as a child are now, in the United States, 50 or older. And in most other countries, a bit younger than that. But still, the majority of the population has not been vaccinated, as well as a changing geographic distribution of human populations that is kind of interposed now with increasingly with the potential animal host for this virus. Next slide. So these are photographs of MPOX lesions, and as you can see on the upper left, it kind of starts as either a macular kind of punctated lesion developing a pustule over time, and then it can have these typical pox lesions which have umbilicated centers, as you can see on the right and in the patient's hand. These lesions can be fairly typical over time as they evolve, but our evidence is that there are other potential causes of lesions that can be confused with MPOX. And so in our tests over the past few months, we've seen about 1/3 of samples collected from patients who have lesions are positive for MPOX, and then about 2/3 are from other causes. So typical lesions can occur, sometimes atypical lesions, but testing is still required to be confirmed about the diagnosis. Next slide. And then I just wanted to mention that although it is usually a self-resolving illness over 2 to 4 weeks, it can be quite serious, and the lesions are often extremely painful. It can, have lesions coalesce, develop necrotic centers. Despite treatment, they can cause scarring and strictures. You can have secondary bacterial or fungal infections. And then ultimately, for people, particularly who are immunocompromised, you can get multi-system organ failure. And we have had some deaths associated with MPOX infection during this outbreak over the past few months. Next slide, please. So the outbreak of MPOX is part of a syndemic. First, about 96% of the cases, both in the United States and in other countries have occurred in cisgender men and about 3% in cisgender women and 1.6% in transgender men, women, or people of other genders. The majority of the cases for which information was reported were in gay, bisexual, and other men who have sex with men. And then we have about a third of cases among African Americans, a third of cases in Hispanic Latino persons, and a third are in whites. And about 40% of cases have occurred among people with HIV, and about 40% of cases have had an STI diagnosed in the past year. 1/3 of cases reported more than 5 sexual partners in the past 3 weeks. And although, this outbreak in the United States is primarily associated with sexual contact, but cases have also been associated with caregiving, events that what we call nosocomial events from transmission in clinical situations, and other kind of traditional ways that Mpox has been transmitted in the past. But the majority of cases in this outbreak are from sexual contact. Next slide, please. So people really matter, and I just wanted to highlight here that for Mpox and for our other kind of epidemics in our syndemic, you have to monitor incidence and morbidity across different groups. You have to look at the disparities that naturally form in an unequal society and prevent them from occurring in your outbreak by thinking proactively. Embrace holistic approaches to health and well-being and kind of multifaceted outcomes. So we have to think beyond just one disease. We have to think about the holistic health of a person, including multiple different negative health outcomes that you're trying to prevent. And then valuing strong partnerships, community leadership, and lived experience is essential. And all of these factors came into play for the Mpox response. So I think it's part of the reasons that we were more effective than we might have been in this response. Next slide, please. So the community did respond when Mpox first started occurring in the United States among MSM. There was an ongoing internet-based survey called the American Men's Interview Survey, which showed that there was about a 50% reduction in risk behavior by MSM in the nation. So people tried to protect themselves and protect their loved ones. Next slide, please. We also were fairly rapidly able to start vaccinating the population. Since the beginning of the outbreak, we've had about 1.1 million doses of vaccine have been administered. About 700,000 people have had first doses. But as you can see in this figure, the overall number of people being vaccinated has decreased over time, and that is of concern if we want to make sure that all the people who are potentially susceptible to Mpox would have immunity. Next slide, please. However, both of these factors, behavior change and vaccination, have seemed to have been relatively successful. Although the overall case count is close to 30,000 since the beginning of the outbreak, we've seen a considerable reduction since its peak of since July and August of this year to under 7 cases a day on average most recently. So the epidemic curve continues to decrease, and our goal in public health is to continue this trajectory. Next slide, please. However, I wanted to highlight here that some of the disparities that we've been monitoring have been somewhat persistent. On the left, you can see the same epidemic curve, but divided by race and ethnicity. And what you can see is regardless of race or ethnicity, there's been over 95% reduction in incidence of Mpox. So we've done well in bringing interventions to people. However, the relative disparity by race and ethnicity is actually increased. And you can see that the light blue bars in the right figure, which represent the proportion of cases who are African Americans, has actually increased over time. Next slide, please. So in addition to kind of people mattering, place also matters in this systemic approach, that there can be extreme disparities in geographic distribution of disease. Resources are often not distributed equally, either at the local level or at the broad country or even global level. Social and economic determinants manifest themselves at the local level. And it's very important in public health to bring services to where people are and make prevention easy. So next slide, please. And I just wanted to highlight here, kind of to honor in some ways the concept of a geographical syndemic. So what you have here is the dark red are the 50%, are the counties in the United States that represent 50% of HIV diagnoses, and these are the EHE counties. And then in the peach color, we have the additional 25% of cases in those in counties. And you can see that even in this situation where there are over 3,000 counties in the United States, about 75% of diagnoses of HIV are occurring in only 148 counties. Next slide. And this slide is a similar map, but conducted with HIV, but also chlamydia, gonorrhea, hepatitis B, acute hepatitis C, syphilis, and our TB. And so kind of many of our syndemics are combined, and we used a measure of kind of where are over 50% or more of the diagnoses occurring in these geographic counties. And what you can see is that the map looks quite similar. Next slide. And then this is a most recently made map of MPOX cases in just the last 2 weeks of October. And you can see again that the counties most affected are very similar to the counties that are also affected by STIs and HIV and acute hepatitis. Next slide, please. So part of the way we were able to address MPOX in the country was by engaging with communities and from the very beginning, highlighting both the equity issues and trying to respond to them. So we've incorporated that approach as one of our goals in the incident command structure at CDC, and many of state and local health departments did the same. We tried to bring fact-based messaging out to people, and we've focused on digital media, dating apps, and other channels with some specific information to help gay and bisexual men. We continued engagement with communities, leaders, and influencers throughout the US government. And there was, we provided guidance to integrate equity into the distribution and access to vaccination, including vaccine equity programs that have reached tens of thousands of people. Next slide, please. So we also worked on place-based interventions. So we ensconced routine MPOX vaccination in clinics that provide HIV, STI, and PrEP services and linked with community-based organizations. And I'm sure that our colleagues from HRSA will be able to highlight how this was done, but it's very impressive in many ways to bring services to people who are coming to the clinic at any, for other reasons or because they were interested in getting vaccinated, to be able to have it right there in a trusted environment. We also are increasingly trying to normalize MPOX prevention and treatment as part of STI services. We will need to continue venue and event-based vaccine equity initiatives, especially during times where people are coming together, and we need to nurture engagement with local community organizations and leaders over the entire response as well as into the future. Next slide. So as policy also matters, policy can maximize reach and effectiveness of interventions. It can leverage existing systems. Policy and law can provide long-term solutions in ways that some specific programs often are unable to. And policies can lead to behavior change and improve public health. So next slide. And in this slide, I just wanted to talk a little bit about the state of syndemics and MPOX. First, in terms of policies, there's been an inadequate STI infrastructure for many years, and Dr. Mena will touch on this in more detail. But we have that happening in an environment of systemic homophobia and racism and economic policies that are associated with increased STIs and some of these major racial and ethnic disparities that we see in public health. MSM and transgender persons bear the largest burden of STIs and HIV, and the context for prevention has changed with U=U and PrEP and reductions in HIV incidence over the past few years. And we are also seeing increasing incidence of STIs for the past several years. And what happened late upon this was a rapid spread of a rare viral infection with scientific unknowns, essentially a gray swan. It was something that had been talked about as possible, but was thought of as unlikely. And because of some preparations that were already conducted, including having some vaccine available through the Strategic National Stockpile and some diagnostic capacity available, we were able to more rapidly respond to MPOX than we were to some other recent epidemics. Next slide, please. So some of the policy interventions was to allow flexibility and in our existing funding streams to incorporate MPOX. So not just from CDC, but also HRSA and SAMHSA, we're able to say within the resources that you're already getting you can, in conjunction with those activities, incorporate MPOX. We provided specific MPOX resources to community-based organizations through small grants and to health departments. We can ensure collaboration between communicable disease and STI HIV programs and their institutions, often working kind of separately because they have different populations that they work with and different diseases. But in this case, we needed to work together. We have developed and made available some toolkits and guidance, including things related to how to deal with MPOX in clinics and correctional institutions, in sex venues, in schools, how to do testing and vaccination and treatment. And we continue to kind of update these toolkits so that people can access the information that they need. And we need to continue research and treatment in vaccine effectiveness and mode of administration, in understanding these animal reservoirs and zoonotic risk, and also better understanding the viral shedding and transmission dynamics that we've been facing with MPOX, and then also to continue to develop new diagnostics and continue surveillance. Next slide. So, and I want to just highlight that the science really does matter. So in this situation, there was a vaccine for MPOX in the Strategic National Stockpile, but because we hadn't had a large-scale outbreak before, there was limited data on the safety, efficacy, and durability of immunity, and we need to use kind of the information we have to be able to answer some of these questions. There was a potential treatments available, but there was limited data on their effectiveness, again, because we hadn't been able to use them in trials up to this point. There were some accurate tests available, but there still is no point of care diagnostics in the United States related to MPOX. So we can't really bring point of care testing to the places that it's needed. And there's been years of research on the transmission of MPOX, but previous outbreaks had really not been associated with sexual contact. And that, and that presented new challenges for our response. Next slide, please. So some of the challenges that we do have are, vaccine uptake is decreasing. We need to think about how we can motivate increasing uptake. Intersectionality increases the obstacles for African American and Hispanic and Latino, gay, bisexual, and other MSM and transgender persons. The public health has been criticized for increasing stigma by providing focused messaging for gay and bisexual communities, but also criticized for not highlighting disproportionate burden experienced by MSM and persons with HIV. And so there's this balance that has been a struggle to do effectively in this response. And one of the questions that we continually ask ourselves and should ask ourselves is what policy systems, infrastructure, and resources need to be in place to both respond to what we're seeing now and to prevent a resurgence of MPOX. Next slide, please. So just lastly, I think some of the key actions to address the syndemic that are consistent with how to deal with MPOX are we have to put people first. We have to continue to focus on equity, put your money where your epidemic is, and put your attention there as well. Leverage policy as a public health tool and to continue to prioritize innovation. So thank you. That's the last slide.
Thank you so much, Dr. Merman. Our next speaker is Dr. Leandro Mena. So I will turn it over to Dr. Mena.
Thank you, Marisa, and thank you, John, for such a great introduction, and in many ways a segue, to my presentation. Next slide, please. And good afternoon, everyone. Thank you for allowing me to be here today and to share, how we in the Division of STD Prevention have been working to incorporate syndemic approaches and how we see a move, towards a more holistic, patient care and patient-centered care. Next slide. These are my disclosures. Next slide. So to start, we continue to see STIs increasing with 2.5 million cases reported in 2021. With chlamydia, cases saw an increase after experiencing a steep decline in reported cases in 2020, likely due to reductions in chlamydia screening in 2021. Increase could suggest improving screening coverage. However, chlamydia cases counts remain lower compared to 5 years ago, indicating that there are still some significant barriers to screening. With gonorrhea, we saw almost 700,000 cases reported in the US in 2021. So during 2020 to 2021, we saw a slight increase in overall gonorrhea cases, around 2.6%. With syphilis, with almost a little bit over 121,000 cases of syphilis reported, we saw the biggest year-to-year increase from 2020 to 2021 of about 26%. This is the largest annual number of cases that we have seen with syphilis in 73 years. As a matter of fact, it was in 1948 last time that we saw such a high number of cases reported with syphilis in the United States. During 2020 to 2021, the primary and secondary syphilis rates among women increased 49%, and the rate among men increased 19%. But the most dramatic, and I think in many ways tragic increase, that we saw was in congenital syphilis cases that were up 24% over 2020 and have nearly tripled in just 5 years. Preliminary, 2021 numbers are reporting 2,677 infants with congenital syphilis and 211 congenital syphilis-related stillbirth and infant's death. Even one of these is too small when this can be prevented through access to prenatal care that includes screening and timely treatment. But I think the important thing is to recognize, as Dr. Mermin mentioned in his presentation, that our STD epidemic is characterized by important disparities. They are geographic, racial, ethnic, based on risk of transmission, as men who have sexual contact with other men are disproportionately affected by many of these STIs, and then age-related disparities, as younger individuals, age 14 to 25 years old, that only represent 14% of the US population, represent about 52% of all reported STIs. Next slide. So when we think about the future of STI prevention and control in reducing STIs, understanding past pitfalls and learning from challenges will define our future work. And the past few years with COVID, monkeypox, this year, polio, and overlapping epidemics of influenza, RSV, have taught us much about public health and our society when it comes to infectious disease prevention. Some of the big lessons there, is recognizing that infectious diseases are a whole society issue, the health inequities must be understood in their source, the timely access to quality data is needed, and that innovative strategies are critical to infectious disease prevention. For instance, the convergence of digitalization, diagnostics, and information technology has allowed us to have a connected system that allows testing data to be turned into intelligence in real time to inform control strategies. Digital technology has long been thought as a game changer for many aspects of healthcare delivery, but digital technology adoption remains low in most healthcare organizations. So when we look into the recent innovation, specifically in regards to STIs, these past few years, we saw STD Express clinics allow walk-in STD testing and treatment without a full clinical exam. As we saw the explosion of telemedicine used not only for treating patients, but for conducting disease intervention services. When we look into incredible work that public health laboratories did with COVID, we saw just how quickly we can pivot our work. And an example is how New York City sexual health clinics were basically using point-of-care nucleus amplification test, were pivot to diagnose COVID diagnosis, and how Denver Public Health Laboratories very quickly developed a rapid test for COVID-19. So I think that all that technology and capacity has been used for COVID has the potential to be harnessed, and to be once again pivot, to support the increasing need for sexual health services in our country. So this may not be so much of lessons as lessons we need to learn or bring back into focus. So much innovation took place these past few years. How do we continue to harness these innovations and adapt that to improve less stigmatizing sexual health services? Next slide, please. So as Dr. Mermin mentioned, geographically, chlamydia, gonorrhea, we see the highest rates in the South. For syphilis, the highest rates are in the West. When we look at geographic trends even further, we see that most STIs cases are concentrated in the larger metropolitan areas, with 50% of chlamydia, gonorrhea, and primary and secondary syphilis come from just 102, 78, and 50 counties, respectively. These counties account for 3% of the US counties in the United States. We have opportunities to really leverage STI diagnostics, and particularly syphilis, as a sentinel event that creates an opportunity for linkage to HIV prevention and linkage to HIV care in areas of disproportionate HIV risk, which are the EHE jurisdictions. Next slide. So 7% of sexually acquired HIV infections in the general population are attributed to gonorrhea, chlamydia, syphilis, and trichomoniasis. This translates into 2,349 HIV infections in 2018, with a lifetime medical cost of over $1 billion. 1 in 10 of incident HIV infections in MSM aged 18 to 40 years in the United States could be attributed to gonorrhea and chlamydia, which translates, again, in almost 2,500 new HIV infections in MSM in 2018. Among primary and secondary syphilis cases with reported HIV status, we know that 44% of those cases among men who are with men are men living with HIV. Next slide. So, besides geography, we understand the impact of the social determinants of health, it's really important that interventions are tailored to the local context. We support, at DSTDP, we support locally designed and implemented interventions to address congenital syphilis and syphilis in women of reproductive age in 4 jurisdictions. And this is an example of 4 jurisdictions: Arizona, California, Colorado, and Florida. The intent of these projects is to help build the portfolio of effective, scalable interventions to counter the rising rates of congenital syphilis in the US. Each site has developed and begun implementation of interventions in their local areas. Arizona has focused on partnering with the North Family Partnership, a nonprofit organization working with vulnerable pregnant persons with their first child. California partnered with an FQHC lookalike to open pregnancy connections, an open access prenatal care clinic targeting prenatal persons experiencing homelessness and or substance abuse. And Colorado is integrating emergency department testing at Denver Health and hospitals, testing also at substance use treatment centers, and testing in county jails. Florida is launching emergency department testing in the Jackson Memorial Hospital system and testing in a substance abuse treatment syringe exchange program in partnership with the University of Miami. All these projects include a significant component of community involvement, which is necessary for any of these equitable approaches to be equitable. Next slide. 7%. I mentioned this. The next slide, please. Sorry. So it's important to know that 4 in 10 acute hepatitis cases, acute hepatitis B cases in the United States are transmitted through sexual transmission. And I'm not going to go over monkeypox again, as Dr. Mermin, clearly, stated the relationship that exists between monkeypox and sexually transmitted infection and HIV. But we have to, it is important to recognize that although monkeypox is a zoonotic infection, it really continues to be part of the world and can be transmitted in many different ways. And this kind of syndemic approaches that treats patients holistically according to their life experiences rather than according to our categories of disease has the potential to broadly reduce transmission of STIs. Next slide. So in September of 2019, next slide, please. In September of 2019, supplemental funding to the division flagship cooperative agreement, STDP, jumpstart our division's activities to support the EHE initiative. We wanted to make sure that DIS workforce funding was integral of our new syndemic approach, and we make sure that in our efforts of expanding and enhancing frontline public health staff, conducting DIS workforce training and skill building, building organizational capacity for outbreak response, and evaluating and improving recruitment, training, and outbreak response, there was a component of an understanding of the disease agnostic that allow syndemic approaches. But I think the biggest demonstration and opportunity has been really with the EHE, the HIV epidemic, and the minority AIDS, HIV/AIDS health funding to a specialty STD clinics. Next slide. So as you can see here, yellow icons demonstrate the counties where we have Part C components of the EHE that have been funded to integrate HIV prevention into existing, sexual health services in these clinics. Next slide. And here are the minority AIDS, health fund clinics, which although don't receive direct funding through our national network of prevention training centers, receive technical assistance to be able to integrate this syndemic approach that in many ways represents, I think, the beginning of an opportunity to scale up, the syndemic approach that we've been talking about. Next slide. So with our EHE work, much progress has been made in strengthening STD specialty clinic infrastructure and provision of HIV prevention services. You can see here, these are data submitted by 38 STD clinics that include our componency clinics, our MHIV clinics, for the reporting period of January 1st, 2021 to December 31st, 2021. So in spite of the challenges presented by the COVID-19 pandemic, these clinics were able to test over 137,000 individuals for HIV, were able to diagnose over 1,000 new HIV infections, were able to identify over 5,000 individuals who were previously diagnosed with HIV, many of which were linked or relinked to HIV care, and were able to start over 6,000 individuals on pre-exposure prophylaxis that previously have not been taking pre-exposure prophylaxis. So next slide. Many of these clinics, this is when we look at the services offered, we see that most clinics offer extragenital chlamydia and gonorrhea testing, along with STD express clinics. We almost made great strides in increasing HIV testing and linkage and facilitating access to PrEP, with most clinics conducting risk assessment and PrEP education, linkage and referral. However, only 1/3 of the clinics have on-site PrEP treatment, which I think demonstrate a great opportunity that how much better we can do, as we know that when people get on-site PrEP offer on-site, the possibility that people will accept, pre-exposure prophylaxis is so much higher than if they're referred, somewhere outside. So again, as I say, this is the beginning, and there are great opportunities. We also supporting the great opportunities, where how many of these clinics could be used to deliver vaccination of individuals, who may be, for whom this may have indication, including hepatitis A and B, HPV, now with meningococcal vaccine, and now with monkeypox. These are perfect setting for delivery of monkeypox vaccination when people are receiving sexual health services or receiving a diagnosis of STIs or HIV. So we also are supporting projects to examine the effectiveness of co-locating STD services at harm reduction services sites to facilitate STD testing and treatment among these vulnerable populations. So as we continue in our journey to reducing, next slide, please. Next slide. As we continue our journey to reducing STIs and other infections and substance use, there are 3 items I'd like to put into action, given the importance of a syndemic approach. One, Dr. Mermin talked about the flexibility in our NOFOs, right? But along with that, needs to be some increased, accountability. CDC and public funded STI programs can really not do this alone. And it's going to take everyone to succeed. Local health systems, clinics, community-based organizations, healthcare, industry, private sector players, and healthcare providers. We have to re-envision how we provide prevention services. This means reaching people where they are with these services through increased screening, awareness, integration into non-traditional settings, and moving to a holistic approach, patient-centered care, including considering who and how people are and their unique experiences. So we have to drive innovation, particularly in bringing STI prevention into the 21st century. We desperately need new tools of all stripes, new approaches, enhanced laboratory capacity, treatment innovations, and vaccines to even the play field. And finally, STIs, next slide, please. We know are a collective responsibility that will require holistic, patient-centered care to close existing gaps, create lasting change, and realize a society where people and communities are empowered to achieve sexual health and protect themselves from other STIs. Next slide. Thank you.
Thank you so much, Dr. Mena. And our next speaker, following this on the next slide, is Dr. Laura Cheever. I will turn it over to her for her presentation. Thank you.
Great. Thank you so much. And thank you so much for both my CDC colleagues for really laying a ton of background. Next slide. So I'm going to talk specifically about what we're doing in the context of the Ryan-White HIV/AIDS program in terms of federal collaboration and having a more syndemic approach. Next slide. No disclosures. Next slide. So I like to start here at our vision and mission. Vision is optimal HIV care and treatment for all to end the HIV epidemic in the US. And our mission, importantly, is to provide both leadership and resources to advance HIV care, to improve health outcomes and reduce disparities for people with HIV. And we've been able to document over the last 11 years that actually we have worked to successfully reduce disparities in health outcomes for some key populations. Next slide. So I think the Ryan-White program at its base is a health equity program. The fact that we're able to provide medical care, medications, and essential support services like transportation, housing, and food assistance, for example, really let us dive into providing support around the social disparities of health. I think in a meaningful and integrated way within the context of the program. In terms of what we've been doing the last few years in terms of promoting health equity, we've really tried to be much more intentional about our strategies, and I'll review them here really briefly. First is community engagement. This is inherent to the Ryan-White statute that we have planning councils and you engage people with lived experience as you do planning. We have, though, been more intentional about putting more resources from the HRSA level to really make sure we're having good community engagement across the board. This included community outreach efforts and listening sessions in 2019 in person, in 2021 virtually. And in 2023, we are actively engaging with BIPIC and CDC, who had been parts of our community engagement in the past, but really from the get-go to integrate into a combined community engagement effort, really, once again, asking people how we can better do work around the syndemic approach. So very relevant to what we're talking about today. The second strategy we use is data utilization, collecting client level data and demonstrating health disparities, and then asking people to act on them. And how do we act on health disparities? Well, the first thing is we have employed continuous quality improvement in our efforts. We have quality management as part of our legislation, but we really focused on collaboratives and using quality collaboratives, once again, with people with lived experience as part of the coaches, and have made tremendous improvements on those clinics when we focused on disparities in specific populations. The other piece we focused on is employing implementation science. 11 years ago, when we first documented we had some significant disparities, clinics came back and said, well, okay, what do I do differently to engage young Black men or young people or people that are unhoused? What can I do differently? And so we have been deliberate in collating and disseminating evidence-informed and best practices, evidence-informed practices, and putting them in locations such as our best practices compilation, so that clinics can reach in and figure out which interventions that are known to work will work for them and how exactly to implement them. The last area is around service delivery. Once again, because we do fund things like housing, food, and transportation, as well as clinical services, we are able, in the context of the program, to address some of the social determinants of health that are actually at the root of many of the syndemics. Next slide. So this is our 2021 data. I'll just spend a minute here. First, just to say that we reached in 2021 over 575,000 clients, which is over half of all the people with diagnosed HIV in the US, which speaks to how much health disparities there are, since our program is primarily a program of low-income people, and yet we're serving over half the people with diagnosed HIV in this country. Our viral suppression rate continues to increase this year to 89.7%, and I can tell you that based on an MMWR that was just published on December 1st, it clearly demonstrated that all of you that are working in Ryan-White programs across this country did an incredible job during the pandemic. We didn't really drop a stitch. You quickly adjusted how you did your work. We gave you a little bit of money specifically for COVID-related funds to be flexible, and you use that to keep people engaged in care and continue to improve viral suppression and reduce disparities. Our program is about 2/3 minority populations. About 11.5% are living in temporary or unstable housing. Almost half are now over 50. and about 60% are less than the federal poverty line. So our program really is reaching the people that Congress intended it to reach. Next slide. So the National HIV/AIDS Strategy, I think for me, as a federal employee, has been one of the most important tools that we've used to really make sure that we are collaborating across federal agencies and now taking a more syndemic approach. So I want to thank Harold and his leadership on the latest version of the strategy, but it does bring us all together as federal agencies and asks us to work together better and differently. Next slide. So our four biggest collaborators, I'm just going to mention here, I think first and foremost is the CDC. We've worked very hard over the last few years to work together, to weave together HIV prevention and care, which in the United States have been very stovepipe traditionally in the past because of the way Congress funds and gives authority to both CDC and HRSA for different pieces of this. One example of us working together is around integrated planning. We have a required comprehensive plan that our Ryan White clinics or our Ryan White jurisdictions need to do as part of our legislation. And CDC also has comprehensive planning as part of their flagship health department grants. And so we put out guidance several years ago and continue to provide support on this for jurisdictions to submit one plan where they weave together their prevention and care activities. Another area of collaboration for us is with HUD. We know that housing is one of the big drivers of people being out of care or not being successfully virally suppressed when they're in care. We've worked closely with HOPWA in the past, but now we are really expanding to try to figure out how we can bring broader HUD resources beyond HOPWA to people with HIV to better provide more services, since we know that HOPWA services in and of themselves are insufficient for the need we have. Third area of collaboration is with the Indian Health Service. Many AIAN populations receive their care in the context of Ryan White, and more recently we've begun working with IHS to look at our data and their data so we get a much better picture of what is happening among AIAN populations in this country. It's been really important, and Rick Fabricate's been a great partner in that. And our most recent collaboration, which has been super important, is with the Administration for Community Living, or ACL. They provide funding for services for older people across the nation. As our population has aged with HIV, we have really called on their expertise. So we've been linking our recipients to learn more about all the services and expertise that ACL has in their communities or funded in their communities, and make sure that the ACL funded organizations know about Ryan White. As a result of this collaboration, ACL, in their guidance to their recipients about the state planning they need to do, they've told them specifically in that guidance to provide, to think through the increasing needs of older people aging with HIV, as well as with the LGBTQ population. So I think that's been a huge win and will help their recipients understand the needs of our recipients and look into that a little bit more closely. Next slide. So in terms of addressing syndemics, I think it was really helpful to us that the department a couple of years ago was working on the HIV strategy, the STI strategy, and the viral hepatitis strategy all at once, all three of the strategies. And although they remained three separate strategies and still are, I think the fact that Harold, who now sits at the White House, was sort of providing input into all of those has really helped us think through how these various areas of epidemics in the United States actually, we really do need to take a syndemic approach. So I just wanted to point that out. I think that's important. Next slide. The other thing that is, I think, helping us think through syndemics a little bit better is the concept of the status neutral approach. And this is really was based initially on providing high impact prevention, so that, for example, if a transgender woman who is very high risk of HIV comes into a program and tests positive for HIV, she's quickly transitioned into a full array of Ryan White services. But if she tests negative in many places, that's the end of it. Come back in 6 months. Well, I think the status neutral approach saying no matter whether you test positive or negative, you have a sort of a suite of services provided for you based on your need. We've been working closely with CDC on this. I think Dimitri Daskalakis has certainly been the champion of it, and continue to look for work from CDC and HRSA encouraging and providing TA to recipients on how to take this approach. Next slide. The other piece I already spoke about earlier is implementation science. This is helping us get evidence-informed interventions and evidence-based interventions and emerging strategies, package them and deliver them to recipients who want to have specific interventions for some key populations. The work we've done in implementation science for many years has included the National Institutes of Mental Health and CDC. And this has been, once again, a very close collaboration of us working together. Our footprint in Ryan White is clearly in the implementation side of implementation science. NIH is clearly in the science part of implementation science and making the science more effective so that we can better implement interventions. And the CDC has a foothold in both places. Next slide. So just one example of implementation science here. We have we've had a series of intervention of initiatives. Our most recent one is 2IS, where we fund one organization competitively, and in this case, it's the Fenway Institute in Boston, who then funds implementation science, the adoption and evaluation of 7 innovative strategies in community-based organizations in 4 distinct areas. So they're working around people with incarcerated experience, LGBTQ youth, those with substance use disorder, and better implementing telehealth. So from that, they will learn how to actually implement these strategies in community-based programs and have these community-based programs also increase their capacity to do this kind of work. Next slide. So just a quick list of a few of the different ways that we have had sort of looked at syndemic approach within the Ryan White program. So the Ryan White program, because there's a heavy representation of gay men with HIV who have both syphilis and monkeypox, we have for many years really focused on making sure that Ryan White clinics are thinking strategically about STI. So an example of that is we funded recently an activity to better link STI and HIV surveillance data in states that or cities that did not have good linkage between the two, because that data is the first step. We've also funded an activity through Rutgers where we are really trying to, we've developed a toolkit for people to better do extragenital site testing. And Dr. Main has been helping us with that and gave us some input early on that. So those are some examples there. Certainly, in terms of the opioid use disorder, we've been trying to make sure that the funding and resources that have come in from SAMHSA, which have been extensive in the past 10 years, that the Ryan White clinics, Ryan White clinical programs and other programs know about that and understand that, and that the SAMHSA funded sites also understand about Ryan White and our needs, sort of trying to broker marriages there to better utilize those resources. In terms of aging, we've just recently published a competition, or just recently concluded a competition to develop new models of care and look at models of care that better meet the needs of older people with HIV. For hepatitis C, that's been work we've been doing for a decade to understand how we can take that broader public health approach to making sure hepatitis C treatment happens in Ryan White clinics. And we've learned that a lot of it, once again, is based on data. So we've been funding programs to better link the hepatitis C untreated data in the context of Ryan White, make sure clinics know about this, and go through and get people treated and cured for hepatitis C. I'll just, in the interest of time, I'll just skip down the COVID-19 response. We had a little bit of money and you all did amazing things with making sure that people stayed in care. That was primarily what we were trying to do, as well as protecting patients and their loved ones from getting infected in the early days. And finally, the monkeypox response. I think Jonna mentioned this briefly. We have had funding directly to our clinics so that we could get monkeypox vaccine to clinics, to the people that are highest risk. And with that, I will stop. I look forward to their discussion. I think my next slide is just my contact information. Feel free to reach out to me. And thanks so much.
Thank you so much, Dr. Cheever. And now I'd love to have our final speaker Erna Hughes go into her presentation. So welcome, Erna.
Great. Thank you so much, Marissa. And thank you to my colleagues in HRSA's Bureau of HIV/AIDS and my CDC colleagues who covered really important ground for us and foundational to our efforts in the federal partnership space. My remarks are going to be dedicated to the work of community health centers. HRSA's Bureau of Primary Health Care has the good fortune, has the honor really of overseeing the health center program. And I'll share a little bit of history and contextualize community health centers as a way of illustrating how essential and force multiplying federal partners have been toward enabling community health centers to employ a syndemic approach to primary health care and public health interventions. Health centers have really proven themselves over the past 57 years to be a cornerstone of community-based primary health care, particularly for underserved communities across the country. And our data show that for the first time in the health center program history, health centers are serving more than 30 million patients nationwide. Those 30 million patients represent 1 in 11 people in the United States, 1 in 5 residents of rural areas, 1 in 9 children and adolescents, 1 in 3 people living in poverty, 1 in 5 people with HIV, and 1 of 6 Medicaid beneficiaries. And so again, the reach is significant and deep, and health centers really do employ this long history of whole person, whole community care, which is, by definition, ensuring or embracing a syndemic approach to our work. It is fair to say that federal partners think of health centers as their partners in this work, and they've played an important role in COVID-19, ensuring equitable access to tests and vaccines and treatments. Certainly, we've understood that these past couple of years, mental and behavioral health services are in great demand. And here again, we have health centers stepping up and supplying those much needed services. Health centers often are the first line of care in addressing such challenges as the nation's ongoing opioid crisis. In fact, in 2021, 55% of all health centers, and there are 1,400 across the country with more than 14,000 sites, provided substance use disorder services to nearly 300,000 individuals. Nationwide, a goodly number of health centers are also providing medication assistance treatment. And our 2021 data shows that nearly 200,000 patients nationwide receive such services. If we could go to the next slide, please. So let me turn to health centers' work in this space of ending the HIV epidemic. And we've heard again from our colleagues what this work entails, how expansive, how strategic, how based in partnership our work is. And so again, to kind of contextualize what that means for health centers, again, as the partner to federal partners, is that the ending HIV epidemic is a way that we in the health center program will actualize our work in this space. The health center model of care, we believe, embraces this endemic approach, and our health center are partners and underpin this work in the HIV epidemic initiative. Health centers are these important, pivotal resources for communities across the country. And as has been described, we have the benefit and really the expectation that we work hand in hand on implementing the national HIV/AIDS strategy. And for us in the health center program, community health centers are key to this. That partnership, as has been described, is inclusive of 10 federal departments. And the national HIV/AIDS strategy has us, really applying hefty effort in this year and on to 2025. And the national HIV/AIDS strategy features a federal implementation plan that's meant to inspire us and inspire our federal and non-federal partners alike. I have the benefit of working with the very people who you've been listening to. Their thought leadership and their reach really does inform my work and the work of the Bureau of Primary Healthcare as we partner with our health centers. You know, the partners, again, are quite hefty. The White House Office of National AIDS Policy, our linked arm partnership with the HIV/AIDS Bureau, the CDC, NIH, and the Indian Health Service. You know, again, I spent time calling them out for the kind of foresight and commitment that is made and that really does allow us to think about and do hefty work in the HIV/AIDS space and beyond. HRSA's support to community health centers, I think it was Dr. Mena talked about putting our money where our mouths are, is really evidenced by the investments, the grant funding that we've made in health centers across the country. We have invested dollars to ensure that through health centers, there is an increase in patients receiving HIV testing, that there is an increase in patients and the number of individuals prescribed PrEP. There is an increase in folks who are newly diagnosed being connected to care within 30 days. And so that is our intent. And I am happy to say that health centers are meeting our expectations. In fiscal year 2020, we awarded $54 million to 195 health centers. In 2021, we awarded $48 million to another 108 health centers. In 2022, we increased our investment, thus allowing us to bring on an additional 64 health centers. And our request for fiscal year 23 is that of an increase as well, with the expectation of investing in 40 additional health centers, resulting in a total number of 40 health centers receiving our primary care HIV prevention funding. However, that investment really doesn't tell the full story of all the health centers across the country with and without primary care HIV prevention funding, who are really putting their back into it in support of individuals across the country receiving access to comprehensive primary health care and HIV services. So time and time again, it is absolutely true that health centers have answered the call to action to communities in greatest need. It is their ability to quickly adapt, to leverage existing resources, to build new relationships and leverage existing ones to ensure that there is this wraparound service and comprehensive access for individuals with HIV in need of primary care. We'll go to the next slide, please. So this slide and these data tell the story that our investment in community health centers is sound. Our primary care HIV prevention funding has ensured that nearly 9 million individuals are served by community health centers. Community health centers in calendar year 2021 conducted 1.7 million HIV tests, prescribed PrEP to nearly 53,000 individuals, and 85% of individuals newly diagnosed with HIV were linked to care within 30 days. So, I think that saying the point over and over again that health centers play a critical role in ensuring access to traditionally underserved communities is the name of is at the forefront of the thought and practice of health centers. And we know that traditionally underserved populations experience comparatively severe outcomes as a result of coronavirus disease. These disparities in health outcomes arise from many factors. And we understand that syndemic theory provides a useful framework for examining COVID response and other disease diseases that disproportionately affect underserved populations. Ultimately, syndemic theory is a powerful tool for us, for our work with health centers, for our work in partnership with each other. And we employ that as a way to inform practice, as Dr. Cheever described, to ensure implementation science is sound. I'll take you to the next slide. So I think the work of community health centers is best illustrated by me telling the story of two community health centers. I won't do entire justice to how powerful, how intentional, how important their work is, but I'll try to do that to give you a flavor of what that work looks like. So I'll start with a health center that is here in my backyard in Washington, D.C., and that health center is Community Health Center, Unity Health Center, rather. Unity Health Center serves nearly 99,000 patients, and it is a large and expansive health center that pays particularly priority to individuals experiencing homelessness. Part of how Unity Health Center has been so successful is that they have built their work on these strong partnerships. Those partnerships include networks of area hospitals like Children's Hospital, GW, and Howard University Hospital, and partnerships with community-based organizations, social service agencies, and again, really with an appreciation for working with and serving the whole person. Some might describe these partnerships as untraditional. They are, in fact, essential and indeed traditional to caring for the whole person. Partnerships with housing organizations, with meal serving organizations, and that has been woven into the fabric of Unity Healthcare, their work in treating the whole person inside the context of their whole community. Unity Healthcare has used HRSA's Bureau of Primary Healthcare HIV funds to do a range of services, including ensuring that there's access to HIV hepatitis co-infection project management, to ensure that there's access to substance use disorder treatment, and telehealth has been a story of COVID, and indeed Unity Health Center quickly pivoted to the use of telemedicine to ensure ready and continuity of care to individuals served by that health center. Important to their work has also been the use of community health centers. One might describe community health centers as the star performers of COVID. Certainly, we've known them to be star performers in the space of HIV work, and that certainly has been true for how Unity Health Center has used community health workers. Lastly, let me move to, and we can move to the next slide. I'll tell you briefly the story of GA Carmichael, which is in Canton, Mississippi, many miles from Unity, but still as, passionate, as purposeful, as committed to treating the whole person. Is a smaller health center. It's a health center that serves about 13,000 patients a year. They've used American Rescue Plan funding and primary care HIV prevention funding to stand up and launch innovative approaches to care delivery, addressing existing health conditions and those exacerbated by COVID-19. Family Health Center, again, has done such things as mass COVID testing events that included HIV screening, and really worked with community health workers as the trusted messengers at these large community-based events to ensure access and linkage to care. Part of what has been essential, and one of the things that we're kind of proud of, and they talk with in a very proud way, is about ensuring access to substance use disorder treatment for individuals, and really recognizing that stigma stands in the way access, and again, kind of putting their back into eliminating or addressing or taking on the ravages of stigma to ensure greater access to care. So I will go to my last slide with a next slide, please, with a closing message that I believe that it takes a village. Health centers have been, again, a partner to our federal partners, nested inside this village. And, the village is one that embraces collaboration, co-learning, building relationships with national and local partners, collecting and disseminating promising practices, forming communities of practice. I'm pleased to have the benefit of the brilliance of my federal partners, the brilliance and the tenacity of community health centers to do this work. And we welcome this continued energy and commitment to continuing on in work that we find so valuable and enduring. Here's my contact information at the Bureau, and thank you so much for being part of this conversation.
Thank you so much, Erna. So we are going to transition into a brief Q&A part of this presentation today. So I'll just ask our speakers if you want to come on video. I will direct some questions back to you from our attendees. We only have a little bit of time, but I want to make sure we get to a couple of questions. So you can continue to put questions in the Q&A. Our first question actually was from two attendees, and I believe this is really focused on Dr. Merman and Dr. Mena's presentations because it's related to STI diagnoses. The question is, do you think that the increases in diagnoses that we're seeing, that trend in increased diagnoses, is related to increased testing, or is it related to increased disease transmission?
I can take that if that's okay. So that's an interesting question. I think that if we think about COVID-19, right, and the impact of the pandemic in access, to health service, to sexual health service and to routine, screening, we saw the impact of that, in the decrease in the number of chlamydia cases that were diagnosed in 2020, or even in 2021 relative to before, 2020 and 2019 or prior years, right? But what we saw also was an increase in both gonorrhea and chlamydia in spite of that closing, really indicated that STIs continue to increase. And as a matter of fact, we think that the increase that we're seeing in 2021 perhaps has been the consequence of ongoing transmission because of the ongoing transmission of many of those undiagnosed asymptomatic STIs. So I think that, again, the increase is real. We know the increasing STIs started about 7-10 years ago. It really started about 20 years ago when you think about syphilis. But I think that it has really expanded to other sexual networks of heterosexual populations probably about 7 years ago and continues to increase.
Great, thank you so much. The next question we have is, we've been hearing a lot about provider and health professional burnout. And there's a question around how the agencies are supporting either expanding the workforce to address epidemics or even utilizing cross-training strategies or other burnout and workforce expansion strategies. And this could be for any of our panelists.
So I can't see everybody. I don't know if Erna wanted to answer as well. I think that within HRSA, we're certainly have been aware of provider burnout. For the first time, the Bureau of Health Workforce within HRSA has actually funded some workforce resilience funding and grants, including some developing some toolkits to help with burnout. I would say that rather than adding more people is important because people are leaving the profession, but also keeping the people you have is critical. And so in the Ryan White program, we've done some training among our clinicians about, and the AETCs have as well, around the importance of taking a systemic approach to burnout. So it can't just all be about take better care of yourself and self-care. It really has to be about the system of care, valuing employees, and helping manage through some of these mental health challenges and just workload challenges that we've had through the pandemic. So I think that is where I'd start. The other thing is we are going to be recompeting the AIDS Education Training Centers in 2024, which is the arm of the Ryan program, specifically around training, and are really focusing on better engaging in the health centers, as Ernest spoke to, better engaging them in providing HIV screening care and treatment as well.
Great. Any other presenters like to speak to that? Certainly have a.
I could just add that I think that the public health workforce itself, in addition to clinicians, are also experiencing kind of a different tone. There's been a lot of concerns by the public health community. A lot of public health leaders have left this specific area of the workforce during COVID because of difficult work environments. And at the same time, there's been so much work because of the epidemics that sometimes it can become overwhelming. So we do have through CDC some resources to support health departments to hire disease investigation specialists and other people to maintain or even expand the workforce. But I think it's a constant challenge. I think one area of encouragement is that public health for some universities is the most popular major. So it looks like youth are inspired by these epidemics, but there's a big gap between interest among young persons and kind of the trained workforce that maintains the public health responses in the United States.
Great. Thank you so much. Excellent responses. The last question I wanted to just pose was around messaging. And I think one of our attendees was asking any strategies that you recommend or you've been utilizing that finds a balance in messaging that is targeted or tailored for a specific audience, but not simultaneously stigmatizing. So I know that's a tough question, I think, to answer, but any thoughts from our panelists on that last question here?
So this is Laura. I think CDC has thought about this a lot, but I think in what we teach in clinical practice is that really sex positive approach towards discussing certainly HIV risk and STI risk as owning your own healthcare and taking care of yourself rather than recovering from something you've done. So more of a sex positive approach.
I would just support that. The kind of a sexual health approach is generally embraced by patients and the community, and also the media matters. So for kind of messages to the general public, often you want to highlight the importance of these the syndemics and the importance of responding, and then the detailed prevention information or treatment information, you want to focus on the populations who need it the most. So if you're going to help people with about PrEP or antiretroviral therapy or getting screened for STIs, really making sure that message goes out through digital media and sometimes other very specific sources can also allow you to reach people in a way that's through a trusted source, and then not increase stigma because it's really tailored for that population.
So I think Dr. Merman made a point that I'll simply amplify, that the messenger is as essential as the message, and the idea that there are trusted messengers that can carry a message in a way that that resonates with communities that we care most about, that we want to ensure that we're culturally responsive to. Again, the vocabulary is important and the medium is important, as is the messenger.
Thank you so much. Well, with that, we'll have to wrap. We have another session starting promptly at 2 p.m. Eastern, 11 a.m. Pacific time. So thank you so much to all of our great speakers and for engaging in our brief Q&A. Excellent presentations. And we look forward to hearing more from you in the future around syndemics and engaging you at Sync again. So thanks everyone for attending, and we'll transition into our next session. Thank you.